This is the Week 16 lecture, Current Issues and Diversity Considerations. Reminders and announcements, this will be the final week of course materials aside from the course project. Quick check-in about grades. Do check out your current grade in the gradebook on Laulima, and let me know if you're having trouble viewing it or if you feel that any of the grades, homework grades, forum grades, etc. are incorrect. If you're concerned about your grade, please let me know as soon as possible, and we can discuss how to optimize maybe your grade on the course project, for example. So starting with the Chapter 3 material on page 71, the US spends more money on healthcare per capita than any other country, and that's not just more developed countries, that's any other country in the world. And there are a number of reasons that people have suggested for this, and I think it's actually a rather complex system, and there are complex reasons, but the fact is that the US has more healthcare burden in terms of GDP and individual costs than any other country. We used to have a system that now in retrospect is called like unmanaged care. So typical systems, healthcare systems in the US used to be fee-for-service, where there was little control by insurance companies or healthcare systems over which clinician or hospitals could be used, and the cost and the frequency and type of treatment were not very closely controlled. Much more common are managed care health systems, and indeed most people are getting managed care these days. And this is a healthcare system in which patients are only able to visit certain clinicians and hospitals if they want to be reimbursed or if they want insurance to cover their healthcare needs. Clinicians within the managed care systems are heavily incentivized to choose less costly treatment options. There is an increase in the monitoring of healthcare cases, and especially in people who may use healthcare systems more, there can be an even intensive monitoring, or it's rather tightly controlled in many cases. There is an increased pressure to use evidence-based treatments, which can be very nice. It's more cost-effective to use evidence-based treatments in general, because if a more effective treatment or evidence-based treatment is used, a patient is less likely to need as much care in the future. Care is going to work better. And in a managed care system, economic control is in the hands of the employers and not the providers, as opposed to in an unmanaged care system where the providers had more control. There are a few models of managed care systems. The primary models are HMOs and PPOs, and then there are some kind of like hybrids and offshoots of these. In an HMO, which is a health maintenance organization, a patient must stay in a restricted network of providers. So this is a major complaint that a lot of people have about HMOs, is that you can only go to certain providers. Service costs are fixed, and you have to get a referral to see a specialist. So in an HMO, you have a PCP, a primary care physician, and you have to stick with that one PCP, and you have to get a referral from that PCP if you need specialist care. In a PPO, which is preferred provider organization, there's a little more flexibility. There are in-network providers, which typically cost less, or there's some incentive to stay with the in-network providers, but you can sometimes go to out-of-network providers, and this is at least partially reimbursed. Service costs are more variable among providers within the system, and the patient typically pays higher monthly rates into their insurance, and typically pays higher premium at their appointments. And then point of service is another kind of like a hybrid of PPO and HMOs. This chart provides a little bit more detail in the comparison between HMOs and PPOs. I'm not going to go through it in detail, and I'm not going to test you on this material. I just thought it was kind of helpful information to have, not just for this course and for understanding the landscape of mental health care, but also just as people, it's important to make educated decisions about the healthcare plans that you might choose in the future. So some of you are of an age where you might still be on your parents' plans, but a lot of you are above that age and have had to make these decisions before. And I think it's, many of you might already kind of know these differences, but I think it's important to really make sure everybody has this information. So the effects of managed care on mental health services are increasingly clear. There has been a higher cost for services for clients within managed care systems. Clinicians are paid less money, are reimbursed less for the services as well. There's a large amount of time spent on administrative work, so there's a ton of assessments, and note-taking can be more rigorously controlled, and in general just higher administrative workload within managed care systems. But there is also, as I mentioned before, this increased pressure to use evidence-based treatments, which creates a pressure to test, more of a pressure to test clinical psychology interventions. As well, there's more focus on low-cost alternatives, such as self-help and group therapy, and the use of master-level clinicians, such as social workers, like clinical social workers, or marriage and family therapists who often complete a master's level program, which can be good and can be bad. There's certainly less rigorous training in most master's programs as compared to doctoral programs, but as well, maybe not everybody needs to go through a doctoral program in order to provide basic mental health care. There's been increased integration with mental health care and into primary health care settings, so people can go see their PCP at the same place that they might see their therapist. And if they use psychiatric services, typically that can be in the same place, the same general area. And as kind of as a consequence of there being more master's level clinicians providing therapy services, a lot of clinical psychologists and psychologists with doctorates are moving more toward supervisory roles, consultant roles, and training roles within healthcare systems. Prescription privileges this is a big controversy in psychology right now, in clinical psychology, and this has been going on for a number of years now. Prescription privileges is the issue of whether to allow clinical psychologists to undergo training where they would be able to prescribe psychiatric medications. And some pros of having clinical psychologists be able to prescribe medications is that there can be a wider variety of treatments to a wider range of clients. It's more efficient and cost effective. So for example, right now, if a client comes in to see me and they need, so they come in for their intake and they need antidepressants as well, or they want to explore the idea of taking antidepressants, I do my intake and assessment with them, and they tell me all the problems, and I get my entire history, and then they have to go to the psychiatrist and sort of go through the same thing over again. So it's sort of like two different intake assessments, and the psychiatrist and I will share some information, but it's still a bit of a redundant process. If some clinical psychologists were allowed to prescribe psychiatric medications, there could be kind of a more efficient system where both services are provided by one person. As well, some people believe that it'll give clinical psychologists an edge, a competitive advantage in the healthcare marketplace. They'll be more marketable and more likely to get more jobs will be open to them. Some cons that people have suggested to prescription privileges. Some people feel that it may lead to a de-emphasis on psychological forms of treatment. So especially in a managed care setting, efficiency and cost effectiveness are extremely important. So some people, there may be more pressure if a clinical psychologist can prescribe medications to just prescribe medications for depression, for example, rather than also engaging the client in treatment, in psychological treatment like therapy, talk therapy. Some people also feel that it could damage the relationship between clinical psychology and psychiatry and general medicine. Like some people feel that it's kind of stepping on the toes or encroaching the territory of psychiatry and internal medicine. And people have rightly noted that this would lead to increases in malpractice liability costs for psychologists. So that's something we don't have to, malpractice is something psychologists don't really have to worry about as nearly as much as medical doctors and psychiatrists. So it's kind of this whole other headache that would be included in the practice. It's been suggested that there are 3 levels of competency, 3 suggested levels of competency if a clinical psychologist were to get prescription privileges. The first would be basic pharmacological training, so knowledge of the biological basis of psychiatric medication and a mastery of the medications that are used and an understanding of how these medications can be abused, of course. And then collaborative practice would be the second level, where the clinician is competent in diagnosing and doing a physical assessment, understanding general physical complaints and issues, understanding drug interactions and side effects, and engaging in hands-on training in psychopharmacology. So that would be supervised by someone, maybe a psychiatrist or maybe another clinical psychologist with prescription privileges. And then at the third level of competency, the clinician would be capable of prescribing themselves. There have been a number of technological advances in the past 10 to 20 years that have also changed the face of clinical psychology. And one of the main areas is telehealth, where services are provided remotely via email, text, phone, or video conferencing. So for example, this is particularly helpful in rural regions where there may not be a psychologist or psychiatrist or other mental health care provider within a reasonable distance of someone's home if they're living on a ranch out in Montana. But there may be physical health services like a doctor's office or a hospital somewhere nearby. And within that hospital or doctor's office, you can set up sort of a like video chat room, and a person can come in weekly or bi-weekly or monthly or whatever they need and talk to a therapist who's in maybe one of the bigger cities that's close by. A friend of mine brought to my attention that there are more and more services online where you can sort of have a psychologist or a licensed professional that you talk to via text. And there are different arrangements, but one arrangement is you sort of pay a monthly fee, which may be rather high, and it's typically not reimbursed by insurance, so it might be up to like $200 a month, but you can text the therapist with a certain frequency and within certain hours kind of throughout the month to get help sort of in the moment without having to show up at an office. This is, I think, particularly helpful for people who have very tight schedules. Maybe they work and have kids, or they're a full-time stay-at-home parent and just aren't able to find the time to get away every week and go to a therapist's appointment. Another area of technological advancement that's been helpful is the prevalence of smartphones. So ambulatory assessment is when a clinician is able to assess mood or behavior symptoms in real time, benefiting from apps or the use of a smartphone. And this is kind of inspired by the fact that people tend to be rather bad at reporting what their mood was a few days ago or what kind of things they were thinking a few days ago. And it's important sometimes in order to understand the link between behavior and mood and thoughts, it's important to kind of get in the moment assessments of what's going on when somebody's having a crisis or when their mood is very low. So there are apps that can be used to get information about that for an individual client. This is also a very popular method that's being used in research right now. There's something called ecological momentary assessment, or EMA, where essentially the same thing is being done within a research protocol to get a better sense of what day-to-day life is like for people suffering from mental health issues. And then finally, there's computer-assisted treatment, where There are apps and websites where people can kind of walk through or do like a self-help mode of treatment. And these things I think can be effective especially with maybe some more straightforward diagnoses. So your book mentioned a trial, kind of a preliminary trial in which people with depression showed improvement using a website that administered sort of a CBT protocol to individuals suffering from depression. But I think there's still more research that needs to be done to kind of assess or figure out which clients might be adequately served by computer-assisted treatment and which clients may need the kind of interactive and dynamic nature of speaking with a person. Ethical standards are always a topic of conversation in clinical psychology. We have a specific course designed in graduate school to cover ethical standards and discuss all of the issues surrounding clinical care that you might encounter in clinical practice. There are some general principles put forth by the American Psychological Association. These include beneficence and non-malfeasance, fidelity and responsibility, integrity, justice, and respect for people's rights and dignity. And these aren't like clear laws or mandates, but guidelines to follow in order to provide best clinical care. There are also some key issues in ethical standards that are common topics of consideration and conversation in clinical psych, and these are competence and privacy and confidentiality. The first is competence, which just means that clinicians should accurately represent their training. They shouldn't attempt to treat or assess in a way that they haven't been trained or in a way that they don't have supervision. So for example, if there's a assessment procedure like a certain cognitive test that someone doesn't have training in, maybe it's a complex neuropsychological test that someone doesn't have training in, they should either seek out supervision in that or read up on it and make sure they're familiar enough to administer it, or they should not administer that assessment. Same with like a treatment modality or certain presentations. So if there was a really severe eating disorder case that came to across my desk, I would probably try to refer out, because eating disorders can require very specific and very intensive treatment that I wouldn't be able to provide. Competence also means that a clinician is sensitive to treatment or assessment issues that could be influenced by the patient's background, racial background, ethnic background, gender, etc. Privacy and confidentiality is the second ethical standard that I want to talk about. We've already touched on this a little bit. What it essentially means is that, to the best of our abilities, clinicians should respect and protect the private information that the client shares. There are caveats to this. Some standard caveats are if a client is at risk of being a harm to themselves or to others, then we might have to break confidentiality and get outside parties involved to keep them safe or to keep other people safe. This is particularly true in the case of child abuse. If a clinicians are mandated reporters, which means that if we hear of a child being abused, we are legally obligated to break confidentiality to take steps to make sure that that child is safe. So for example, I had a client once at one of my clinical settings who unfortunately was addicted to meth, and her partner was addicted to meth as well, and there were several young children that were under their care. And once the client left, I was legally required to contact Child Protective Services and make a report that this person's children were not being taken care of. So it's not just that they were addicted to meth, but they were under the influence of meth so much that the children were at risk for neglect. And so it can be quite harmful to the therapeutic relationship, can be quite destructive to their progress in therapy, but it's something that has to happen. And luckily in this particular case, I was really surprised the client came back. She knew I'd made the Child Protective Services report, and she completely understood that I had the best intentions for her children in mind. So we were able to repair the relationship and continue with a pretty successful treatment course. Another example would be when clients disclose a level of suicidality that indicates that they may be an immediate danger to themselves. So this is relatively common, especially in outpatient treatment with serious mental illness. So several times at my current position and other positions, I've had to, someone came into a appointment and expressed a level of suicidality that made me feel that they shouldn't go home, that I shouldn't let them out of my office. And luckily, in I think every single case, I was able to convince the client to walk with me to the emergency department or to go to the emergency department under the care of the police so that they could be assessed by a psychiatric emergency department and brought to the inpatient facility where they could be protected and observed. But it's often the case that it doesn't go so well. A client doesn't want to be admitted to the hospital, and in that case, a lot of times clinicians have to call the police and do like an involuntary admit into inpatient care. Your book mentions the Tarasoff case, which was a case in the 70s in which a client disclosed that he wanted to kill his girlfriend, I think, and the clinician told the police, and I think the girlfriend was out of town, so the police took the client, but they then released him, and he did end up killing his girlfriend. And I believe the clinician was considered responsible because they didn't warn the girlfriend about this client's intentions. And this kind of set off alarm bells for clinicians across the country because it creates some complications. It's sort of a precedent that has created some complications for confidentiality because it makes clinicians question who they have to inform. So there's a duty to inform for sure if somebody has said that they intend to hurt somebody else or that somebody else is currently being hurt, but it's not clear if the clinician is responsible for informing the parties that the client intends to hurt, or if that's even possible necessarily. So in this case, it might have been the case that the clinician had access to the girlfriend's cell phone number or somehow would be able, or it was the 70s, so had access to the girlfriend's phone number, but to what extent do clinicians have to go to warn people that their clients might be harmful toward them? So it is very complicated. It differs by state. Legal precedent differs by state, and I think even at the state level, it's not always clear. So it's kind of a constant judgment call that clinicians are grappling with. Okay, and now we're going to move into diversity factors. So this is material from Chapter 3, and then some additional material that I've added. I think it's important to go rather in depth into diversity factors in clinical psychology. It's essential to have clinicians that are able to work appropriately with diverse clientele. It's essential to have treatments that are appropriate for diverse clientele, and this includes considering ethnicity, gender, race, age, sexual orientation, disability status, religious beliefs, and more. So culture and race is something that we often talk about when we talk about diversity, but it's by no means the only diversity factor that's important. But it's worth noting that the U.S. population is increasingly diverse, and there have been projections that white people will be the minority in the U.S. by 2044, which underscores the need. It's important to attend to the needs of minority groups generally and now, but it's going to be increasingly important as the U.S. becomes a minority-majority country. So how do you gain competency in working with diverse clientele? There are 3 general guidelines that can be followed under this model. There are many different people have written about this and kind of come up with different models, but I think this one is pretty fitting and simple. So the therapist must be aware of their own assumptions, values, and biases, and this goes for psychological assessment as well. The therapist should work to understand the worldviews of diverse clients, and the therapist should be competent in interventions and strategies, techniques that are appropriate for a diverse range of people. So we'll go through these point by point, starting with a therapist being aware of their own assumptions, values, and biases. So a therapist must be open to exploring these things and their assumptions about human behavior. Of course, they must actively avoid believing in the superiority of their own group's heritage, and this is more than just not being a white supremacist or not thinking that, for example, like women are better than men. This is kind of exploring those assumptions that somebody might have even about their own religious orientation or other things that may even be value-based for them. Acceptance and respect for cultural differences is, of course, very important, and actively and constantly trying to avoid prejudice, labeling of people, and stereotyping. A clinician shouldn't negate the existence of group differences. Different people do tend to group together and have certain shared values and shared histories and shared beliefs, and this is normal and something that's worth acknowledging without making the mistake of generalizing that group of people. So there was a kind of a phase in the 90s where to deal with racism, some people would say that they were like colorblind, that they didn't see color and treated everyone the same. And there have since been some people I think have mostly evolved past that in realizing that there can be group differences and there are different people of different races and skin tones have different experiences in the world because of that, and it's worth acknowledging and respecting that. It's important that a clinician be aware of their own limitations and feel comfortable referring a client to someone else. So I am a white person working in a mostly African American or Black population, and if a client we always ask in intake if the client has a preference for people of a certain cultural background, racial background, gender, etc. So if somebody wasn't comfortable working with me because I might not understand some of the issues that a Black person deals with in West Baltimore, I think this would be completely fair, and I would try to find them a clinician that they were more comfortable working with. It's also important that a clinician doesn't deny their privilege or ways that they've benefited from individual, institutional, and cultural biases, and I'll get more into this later. And it's also important that we accept and acknowledge that everyone has biases, that, and this is, there's a whole body of literature called like implicit bias work. Actually, there's a social psychologist at the at UH Manoa who does this kind of work. Everyone has certain assumptions that they make about people that are in different groups. We involuntarily make assumptions about people in wheelchairs, about people of different genders, about people of different ages, and while it's very important to try to correct these assumptions and not let them affect our behavior, it's also important to accept responsibility when it does happen. For the second point, therapists working to understand the worldviews of culturally diverse clients, it's important that a therapist be aware of the history, experiences, cultural values, and lifestyles of various groups of people in general. For example, working as a clinician in Hawaii, it's very important to understand the history of Hawaii. It has a very unique history, and at different times, different groups of people have been systematically disenfranchised and oppressed. And this has an impact on how people live today. And it's something that is clinically significant for a lot of people. It's also important to expose oneself to ongoing education about issues related to these minority groups, so current issues that minority groups might be facing. Because again, this impacts people. So when laws change that, like laws with, like immigration laws change, working with people of certain immigrant groups might be different. This might be something, their legal status or their immigration status might be something that's more salient to them or might be a barrier to them in treatment, and this is important to be aware of. And then as well, understanding the impact of oppression and how it's impacted the field of clinical psychology. So recognizing that clinical psychology has a history of not treating groups like many fields, like pretty much all fields. Unfortunately, throughout history, there have been biased ways of treating different people. And so acknowledging that in the history of clinical psychology and actively working against that is also important. We should also be aware of the assumptions of normality and abnormality and how they're culturally bound, how someone might be considered abnormal in a mainland mainstream US culture, but this might be normal in a different culture, especially a culture that they're embedded in. And then being aware of barriers that prevent some clients from using mental health services. So language is a big one in the US, in Hawaii. Language is a big one. A lot of times when I was working in Hawaii, there would be problems. Clients would not be able to express themselves, and if translation services weren't available, it could be a big problem. It could be a massive barrier to mental health services. As well, hours and days of operation. If certain people of a lower socioeconomic status have like 2 jobs, for example, it may not be as possible to come in during regular business hours. The third point is that therapists should develop appropriate intervention strategies and techniques. So to do this, a therapist might adapt their therapeutic style to diverse clients. And this should be done with indication from the client. So just because a therapist is working with someone of a certain cultural group, they shouldn't make assumptions that that person is necessarily wants you to like mimic the language or the interpersonal style of that cultural group. That can often just be really tone deaf and not effective. On the other hand, well, for example, when I first started working as a therapist in Hawaii, I'm from the Midwest, which is a pretty buttoned up culture, and we don't really like hug people that aren't our immediate family. And I was lucky enough to receive feedback from a family I was working with, a Native Hawaiian family I was working with in Hawaii, that I was just like too formal with them. And they did it in a very kind way, where they were just like, you're too kind of rigid wasn't the word, but whenever they left therapy, they would want to give me a hug. They would want to like bring things for like a treat or something on Christmas. And for me, it was really uncomfortable, but I understood that I need to adapt how I interact with that family to be more appropriate for their needs. On the other hand, my buttoned up style worked better for some of my clients who came from mainland US, especially if they were kind of like from middle America. So being able to be adaptive based on what the client seems to prefer can be very important for therapy. You should also be able to appropriately send and receive verbal and nonverbal messages. So paying attention to nonverbal behavior is incredibly important, especially in certain cultures that might be less confrontational and maybe more dependent on nonverbal communication styles. Also using strategies that are flexible in terms of like getting out of the office, going to people's homes if needed, if that's possible, going to schools, doing consultation or outreach to help clients with institutional issues. So getting into the schools to help kids if there's a problem, a school-based problem. can be effective with different types of clients. This generally falls into the category of not being trapped into this conventional therapist mode of operation that was developed with a pretty mainstream, white, higher educated US population. And then at the end of all that, acknowledging the limitations of ourselves as a therapist and openly communicating and being open to feedback on how they might impact the client. The last thing we're going to talk about in this section is privilege. Everyone's probably familiar with this term. It's been the topic of conversation a lot more in the news and in general conversation. Privilege is being part of a group that benefits from unearned and largely unacknowledged advantages that increase their power relative to that of others. And this doesn't mean that people in a group who are privileged don't have earned accomplishments. It just means that those accomplishments came much more easily and also at the expense of people without those advantages. Privileged groups are generally seen as the norm or the default in society, so a lot of times it's the majority group rather, or the group that's in power. Privilege is often invisible to those who have it, and this can perpetuate privilege because the people in power, if people in a powerful position don't understand that their power is at the expense or their success is at the expense of other people's success, they're less likely to be amenable to this. And indeed, privileged individuals may often feel uncomfortable in acknowledging that part of their success is related to a system that was developed to support them and unfairly lack in support of other people. Also important to note that virtually everyone is privileged in some way. Almost everybody is a member of some privileged group, and most people are also in some way disadvantaged or a member of some unprivileged group. And privilege is an opportunity. Being aware of privilege is an opportunity to learn and gain insight into oneself and be responsible for general social justice and contributions to a more just world, which is particularly important in clinical psychology. I'll talk about a couple different kinds of privilege, but this is by no means exhaustive, and it's not an exhaustive list of types of privilege, and it's also not an exhaustive list of examples of those privileges. So a common one that people talk about lately is male privilege. And some indications of this is language indicating that male is the norm. So the English language is infused with terms that indicate like mankind means all of people. You guys, freshmen refers to people of all genders, chairman. Prestigious occupations are also associated with the male gender, resulting in people differentiating females in these professions. So a male doctor might just be a doctor, but a female doctor might be a lady doctor or a lady boss. In many cultures, there's a favoring of sons over daughters, and this might seem like an old-fashioned practice, but it's very much alive and the case in many modern cultures. There's statistically the chance that a person in charge will be male. Access to leadership positions, for example, in many religious organizations are not available to women at all. The deities in many major religions are usually depicted as men. God's referred to as he. And men have much more representation in politics, at least in the US and in most countries worldwide. Men generally get paid more for the same job as women. You might be familiar with the most commonly quoted figure is women make 77 cents per dollar to the dollar for men when they're doing the same job. Men are also more likely to be promoted despite equal performance among men and women in a job. So if a man and a woman are performing equally, the man is more likely to be promoted. And all of these are based on data, are based on research in the field of psychology indicating this and controlling for other factors like competence and other factors that you might, like extraneous factors. Men are also less likely to face sexual harassment, especially in the workplace. In the general environment, men are less likely to experience sexual assault. White privilege is also very much a part of current conversations, and this is evidenced by a plethora of examples, but some of these include that the person in charge is most likely to be white. Religious figures in the most prevalent U.S. religions are depicted as white. Wage and hiring gaps in white people versus people of color, especially Black people. There's a pretty well-known series of studies in which two identical resumes were sent to an employer who was recruiting to fill a position, and it was much less likely that a person with a Black-sounding name would be interviewed or hired compared to a person with maybe like a white-sounding name or with a not Black-sounding name. White people are disproportionately represented in movies, TV, books, and standards for beauty, at least in the US, mainland US, are more likely to match white features, such as hair. There's housing inequality that's been part of US law in the past. Lower rates of mortgage approval for people of color, and this has been sanctioned by state and federal laws. There's also education inequality, standardized tests. There's been a number of studies of standardized tests and how they're based on skills and knowledge that are emphasized in white culture. Indeed, the people who developed standardized tests for intelligence and cognitive functioning were almost exclusively white people. And so you can imagine that they would choose to test based on things that they thought were important, whereas people in another cultural group or people of a different socioeconomic status might value other skills and knowledge. Also, minority students are shown to be less likely to be placed in honors classes despite equal test scores. Within mainland US, the way that history is taught and conceptualized is based on a mainstream kind of white perspective, and historical figures are almost exclusively white that are taught in most history books. As well, white people can seem to get away with more in terms of swearing or dressing in certain like secondhand clothes or wearing hoodies, for example, without people attributing this to negative qualities such as poor morals, poverty, or something about their racial status. And finally, white people aren't asked to represent or speak for all the people in their racial group, whereas a lot of people in minority groups are kind of often report feeling pressure that they have to sort of like represent their racial group, or people will ask them to sort of explain or speak for people within their racial group. And finally, there's heterosexual privilege, in which heterosexual people are allowed a widespread and public recognition and support for their intimate relationships. For example, a heterosexual couple can announce on social media their engagement without fear of judgment or retribution. They can buy wedding cakes anywhere they want. They can express affection in most public places without concern for hostile reactions from other people. They can generally expect social acceptance from the people around them. Most romantic relationships in media are heterosexual relationships. The heterosexual people also are portrayed with nuance and in a range of different ways in media, and generally are portrayed accurately in a way that other heterosexual people can identify with, at least to some extent, whereas people who are not heterosexual may be kind of stereotyped or portrayed in a negative way. And then finally, Heterosexual people can find typically role models within their gender and sexual orientation, whereas a homosexual or someone who's just not heterosexual LGBTQ individual might find more difficulty in finding someone in their community or their family with whom they can model themselves after.